Hello, and welcome to Cutting Edge Pain Relief discussion about shingles pain and how to be able to treat it effectively. So, first of all, let's have a discussion about what is shingles and when does pain actually result. And we're going to talk about some different treatment options that are out there. For those of you who are catching this not live, but at a different time, one of the papers that we're utilizing to really be able to give insight, which we'll have included in our YouTube channel, the links below, is the following. And that is the interventional treatments for postherpetic neuralgia systemic review. So what exactly does that mean and why are we choosing this paper? Well, actually, it's a paper that was published in Pain Physician that did a meta-analysis, which in essence is an evaluation of different types of studies. And it looks to see what are the universal truths, if you would, that seem to be able to give us more indications. So for those of you who have had someone that has had shingles, you know how debilitating it can be. But by the same token, those of you who haven't, you probably have heard about those type of issues. And historically, shingles has been treated the same way many other nerve pain issues have been treated. So let's back up for just a little bit and talk a little bit about what exactly is shingles, how does it give you problems and issues, and how can we be able to get some further understanding. So shingles is the development of the varicella zoster virus with a recurrence in the nerve. So let's break this down, as I say all the time, right? We want to make sure that you are understanding what is the problem and what are your options without fancy talk preventing you from being able to really glean how can this be able to impact you or someone that you love and care about in a successful and a good way. So shingles or varicella zoster virus is also commonly known as chickenpox. So if you've had chickenpox exposure before, that nerve that has that virus present can then recur, typically at much later stages in life, and present with that type of presentation that you saw in that original picture, which is a change that's present within the context of the skin. For many people, that can be itchy, it can be a bit burning, but normally it's not always that sustained. If we're using medical terminology that I'm going to explain in just a second, it's frequently classified as a display of an outbreak that's dermatomal in nature. So what the heck does that mean? So a dermatome is an area that corresponds to certain nerve roots. So if we were kind of showing the elements of a spine and really trying to pick that out, basically it would be the following. So if we were to take a look at a model similar to this, you can be able to see that there are different nerve roots at the vertebrae. So we get a degree of focus. And those nerve roots correspond to different areas in the body, right? So when we have that corresponding piece where you have those nerve roots that are saying, okay, this is going to be the thigh, or this is going to be the knee, or this is going to be a rib, or this is going to be a component of your jaw. Each one of those have a strip that's typically associated with some changes in terms of skin coloration and discoloration at the time. That article that you saw referenced earlier talks about a later stage. And that later stage is something that's called postherpetic neuralgia. So what exactly is postherpetic neuralgia? Because I know that that name certainly sounds very fancy, and most of you guys are probably kind of having a sensation like this. Right. So postherpetic neuralgia basically means pain after you've had the experience and exposure, and it can last months to sometimes years. And so historically, we've treated that with different types of medicines, things like Elavil or tricyclic antidepressants or gabapentin and Lyrica, traditional anticonvulsant type medications that many people have heard of, particularly for neuropathic pain. The problem is they haven't always been that effective. And that's one of the reasons why we've looked at some studies for those people who don't necessarily respond to how can you be able to make patients better. And quite frankly, one of the reasons why this came up is we've had a number of patients present to our practice with postherpetic neuralgia recently, and we are talking to them about different strategies on how to improve things. And they've had different types of oral steroids, and they've had different types of traditional injections like epidural injections. But the question is what's the science behind it, and how can we really be able to kind of glean from what are some of the non-invasive to more invasive treatment options to be able to help treat shingles. So when we take a look at this paper, one of the things that we see is that it talks about those very things that I just mentioned, as a matter of fact. So it mentions things like pain medicines, some creams, some different types of treatments like tricyclic antidepressants, pregabalin, and lidocaine patches, right? But really, what they were looking to do was to try to figure out, are there other treatments that can be able to show more sustainable type relief? And what they were able to find is the following, is that when you're treating postherpetic neuralgia, most evidence is level 2. Now, ideally, we want level 1, but there's a few different recommendations that they were able to come up with that made sense. And so what they were able to see, and we're going to kind of jump ahead and then we're going to work backwards for those of you who want the ice cream and cake before you actually have the rest of the meal, what they were able to see was the following, is when you take a look and you actually are able to get into the root of the matter of what were the treatment options that made the most sense, it was actually the following. Is so, as they state, in conclusion, concurrent evidence is insufficient to determine a single best option. However, when you look at invasiveness versus price and safety, the things that seem to work best were injections of either botulinum toxin A, which we're going to talk about, Synalon, which we're going to talk about, transcutaneous electrical nerve stimulation, peripheral nerve stimulation, and stellate ganglion. Those are their first recommendations. So, what are those things and what do they mean? So, some of those things, right? So, you've tried dealing with and preventing all these options, but unfortunately, the pain is there. It's prominent, it's burning in nature, it's intense, it's unremitting. You tried maybe traditional pain medicines, and then it just is not getting better. So, one of the things that has actually been out and really been useful within the context of dealing with shingles pain is the context of being able to use Botox. And most of the time when we think about Botox, we think about it in the context of looking at cosmetics, right? Where it's improving elements of wrinkles or other changes of that nature. Or sometimes we're looking at Botox to be able to be useful in the context of headache management. But in this context, we're talking about how can it be helpful for nerve pain type treatments. And when we get into the underlying nature of how Botox really is able to provide some degree of benefit, one of the things that was able to be seen is the following. One second. Here we go. Okay. So, and you may not be able to see it from there, but there were reviews of a couple different studies that looked at Botox, and what they looked at is pain that was ongoing for greater than 3 months that had a pain score of at least a 5, or in this particular study, a 7. And what took place was Botox was mixed with either saline or a combination of saline and lidocaine collectively together. And the injection was performed with a maximum of 200 units that were typically administered. In this study, it was 100. And what they saw is that 87% of patients were able to have a 50% reduction in their overall pain, as well as being able to improve their sleep score. And so when we talk about that, Botox itself is normally administered with a small 27 or 30 gauge needle with traditionally a tuberculin syringe, so that you can be able to have a minimal small injection into an area that normally is pretty well sensitized to begin with. And so what I mean by that is traditionally this type of pain has something that's called allodynia. So allodynia is, in essence, the definition is if you touch the skin, instead of you having a sensation of just peripheral touch, it's a painful touch that's associated with it. So soft touch, it can be very excruciating. So within that context, doing traditional injections at the site can be pretty darn uncomfortable. So if you can use a small gauge needle that can be able to give you a good degree of improvement, it's certainly something that would be worthwhile and worth the trouble. One of the other studies that has been looked at is the use of TENS. So TENS, as it was mentioned previously, stands for transcutaneous electrical neural stimulation. And so that context had a number of different studies that were looked at. And so when we go back to that treatment option, one of the things that we saw, as if we were to take this off for a second, are studies that looked at patients that were traditionally aged 50 to 80 years old that had tried treatment with things like pregabalin in combination with TENS or other treatment options. And what they were able to see is that the TENS were used for about 30 minutes a day for 6 days out of the week. And then they were able to kind of follow up. And what they saw is on average, it decreased pain by about 30 to 40% in some studies, and as many in some studies in combination, greater than 50% reduction. So I know that I'm talking in sciencey facts and figures and such, but really what the reason why we're doing this is because we want people to understand is it's not just being reliant upon one study, but being able to pool that data, analyze it, and see, can we use that information to deliver better outcomes by refining what strategies we pick. So within that context, what we really want to be able to do is to say, can we pick out tools that have a minimally invasive option, but then also produce a maximally effective outcome? So when we take a look at TENS, for those of you who aren't familiar with TENS, you apply it with a small adhesive patch to the area. And that patch application isn't painful. There's an electrical stimulation that's delivered to the areas of the muscle, and it's not a shocking sensation. It's more kind of like a massaging type sensation. And when it's used with regularity, that can provide relief, particularly for those people who have shingle pain or postherpetic neuralgia type pain. So what are some of the other options that can potentially provide value? Synalon. So it's a fancy word, but as I mentioned it earlier, really what it stands for is for a steroid that's placed at the site. And so when we take a look at what is the corresponding studies that were associated with it, it was the following. So what we're able to see is there were patients that were between 40 to 80 years old that had a randomized control trial where they were treated with triamcinolone plus lidocaine or just lidocaine alone. And what they found is that 63% and 83% of patients have greater than 50% reduction in pain. So for us in our clinic, one of the things that we do is this is one of our starting steps, mainly because most patients that are in this context of having shingles pain traditionally have some form of Medicare most of the time, but not always. And it's one of the ways that we can be able to blend the context of clinical efficacy with insurance coverage that doesn't leave a patient in a short, difficult span. Can you get coverage for TENS? You can. Can you possibly get coverage for Botox? It's traditionally not an indication to be able to treat shingles, but there are ways to be able to cover both with a monetary outlay. But if we don't have to, let's start with something that makes sense. The downside to using triamcinolone or this steroid with lidocaine, so you have to use a little bit a larger needle than what we might with Botox. So it's one of the reasons why we didn't initially lead with it, but it can be able to provide some degree of value. If you are watching this live, please give us a thumbs up and let us know and maybe share it with someone else. If you're watching this as a secondary time frame that's not the live stream, please leave a comment about whether you've been affected by shingles or you had someone close who's been affected by shingles. And please let us know how we can be able to help serve you by talking about various different pain topics. We're going to take a quick break for just a second and continue right after these messages. So I'm Dr. Orlando Landrum, and this is Cutting Edge Pain Relief. What we attempt to do is to be able to have individuals who watch our channels be able to understand why they're having pain, what are their options, and how they can get back to leading the life that they deserve. And today, what we're talking about is postherpetic neuralgia, which also is known as kind of pain post shingles, which is a pretty debilitating pain, which makes many people kind of have the same type of sensation and feeling as this. And what we're talking about are strategies and treatments that can help people be able to get back onto their feet and really feel like they're leading the life that they deserve. So one of the other strategies for potential treatment is the following. It's something that's called a stellate ganglion blockade. So to give you insight about the picture that you're looking at someone directly at their neck. So we're looking straight down and we've had the skin removed and we're looking at that anatomy. So as we're looking at that, this is the aspect of the manubrium, which connects into the first rib. You have the carotid artery and you have the various different cervical vertebrae separated by the disc. You have nerve roots that are covering off, forming eventually the brachial plexus. And on top of this, you have the various different stellate ganglion, which is part of the sympathetic nervous system. So this is, if you would, kind of the brains in a roundabout way of some of the pain that you experience in the neck and the face. Historically, it's been used to treat for things like complex regional pain syndrome and other various different facial pain issues. And by placing medication in this site, you can be able to get a response that can be very difficult to treat otherwise. So if you have that postherpetic neuralgia pain that's in the jaw, that's in the cheek, that's over the eye, sometimes trying to treat it directly with a needle, like mentioned before, for Synalon or Botox, can have some issues and challenges associated with it. Instead, by doing a stellate ganglion blockade, you can be able to get some of those similar type of responses by treating the nerve where it has kind of multiple different inputs that are giving us that value that are in place. And so we have one of our comments from one of our viewers that is, never knew stellate ganglion blockade could treat postherpetic neuralgia. And yes, there are studies that actually represent and show that. So speaking of which, we will cut to it. So what you can be able to see, and maybe it's not as clear from the vantage point of the camera, is the areas of looking at randomized controlled trials of facial hepatic eruptions that really didn't necessarily respond to antiviral therapy. And so what was done was fluoroscopy guided stellate ganglion injections. So as a quick aside, so historically, stellate ganglion blockades are done with fluoroscopy. I'd probably say greater than maybe 80% of the country still does it that way. There are some that do just ultrasound guidance, but really where I think kind of the sweet spot lies is with both. And the reason why is, as you saw in that, or see in this picture, one of the things that we have is that aspect of vasculature that exists. And so you have a couple of different major arteries, one being the common carotid, the second being the aspect of the subclavian artery. And those vessels can have different trajectories. They don't always follow what we would exactly expect. Historically, the way this procedure was done is by taking a needle straight down to the bone and then being able to retract it a little bit. So if you are looking at this, and we're kind of using this as an example, one of the things that you'd see is you'd see this model kind of representing that, right? And there would be a needle that would come in and it would place right on the bone, right? And so you see this being placed right there on the bone, and that placement then would come back just a little bit and you'd have an injection. But the stellate actually lies a little bit lateral to that. But there's a number of reasons for why you wouldn't want to place that needle laterally closer to where the stellate happens to be, because there's some risks that are associated with it. However, by using ultrasonography, you can be able to somewhat diminish those risks by knowing that you have a nerve, that you have vasculature, and you can be able to see it and make sure that your injection is going to the area where you want it to be. But going back to that paper that was talking about stellate ganglion and how it actually has impact, what they were able to see is actually a significant p-value 0.05. And what that means is that they're able to see a treatment group that had benefit for greater than 6 months in time and duration by going after and using stellate ganglion blockade for extended relief. So up until this time frame, we've talked about mainly treatment options that rely upon a needle placement with an injection of some sort in order to then be able to get benefit. And most things have been where we would kind of make a determination about how long would it last. The only treatment that we mentioned that wasn't necessarily percutaneous or piercing the skin was the TENS unit that may be able to give some degree of value. And quite frankly, there's a number of technologies that are out there that might be able to be leveraged with more advanced waveforms than traditional TENS alone. Traditional TENS alone is a square block wave where you kind of have a square impulse that's in place, right? Like from old school physics class. But there are other items out there, like in one video we covered Enzo, which is a phenomenal product that talks about having a composition of multiple different waveforms that all collect together in order to be able to get a much better result. And so from a percutaneous standpoint, there may be some other options that are out there that can provide benefit if you're looking for a non-invasive technology. But sometimes those things don't work, just like sometimes medications don't work. And so that's where we start looking at how can we be able to treat this invasively, but with the intent to be as minimally invasive as possible. So one of those things would be to use something like peripheral nerve stimulation. And so for those of you who've watched our videos, we've talked about this for stimulation of various different body parts like shoulders, knees, and hips for pain relief, as well as our most recent conversation discussing lumbar facet joint pain by using this in a medial branch facilitation. And then one of the things that has been used in this context is for postherpetic neuralgia. By all means, if you are on the live stream and you have questions, shoot those questions in and we'll try to answer them, because I know I'm going through quite a bit of material really rapidly and fairly fast, but I don't want people to get bored. And I certainly want you to understand the different options that are in place and what's the study and literature behind it. So as we get into that context of talking about peripheral nerve stimulation, when we take a look at it and assess it, this is what we're able to see. So there have been a number of different studies that have looked at placement in multiple different areas, right? And so there have been placements at the ophthalmic division of the trigeminal nerve in multiple ones. There's been supraorbital placements, there's subscapular placements, there's paraspinal. So again, what does that mean in regular English, right? So if we're talking about the aspect of the components of the ophthalmic division of trigeminal, we're talking about these areas in here, right? If we're talking about the context of supraorbital, it'll be directly above the context of the eye. We're talking about subscapular, we're talking about context of placement that will be more towards the back of the shoulder. Right paraspinal and upper thoracic also will be deeper as well. And so all those areas can be treated with the context of using a peripheral nerve stimulator. And so the level of evidence isn't as robust as what we want, but in terms of the degree of impact, it's been able to make impact and maybe I'll be able to have it be more sustainable. So one of the things that they were able to see is a change in the score from anywhere from 20 to 30% in some studies. And other studies, they were able to see 50% had 50% of decrease in pain and be able to decrease medications. In others, they were able to see changes in medication use in order to be able to improve overall pain relief. And in others, they were able to see pretty drastic changes from a VAS score of 8 all the way down to 1. So those things, I think, are huge when you take a look and you say, all right, you know what? We've been able to treat this with Botox or steroid or a stellate ganglion block or TENS unit, but it hasn't necessarily been sustainable. It hasn't been able to necessarily last. And now we're back to considering using medication. But those medicines, as we know, can have a number of problems associated with them. They can have sleepiness, they can have fluid gain, they can have dizziness, and a whole host of other issues and challenges for people that are trying to lead their lives. So if we can find a way to be able to decrease or stop meds and be able to improve your functionality and decrease pain, why wouldn't we consider those options? And so some of those things, as mentioned, would be something like would be peripheral nerve stimulation. So we're looking at peripheral nerve stimulation. That begs the question, well, what about something like spinal cord stimulation? So the differences being uh, spinal cord stimulation is the implantation of a lead that will be placed within the epidural space with then a connection outside of that that has a current that changes and influences the spinal cord by focusing predominantly upon the context of sympathetic nerves and how can we be able to change that. In contrast, when we take a look at peripheral nerve stim, there's an implantable lead, but there's typically not a battery buried underneath the skin for most of the time. There's traditionally a transmission of energy to that peripheral lead, and then you can remove this as need be in terms of the battery. And the lead is placed in close context to the nerve that's in question and causing a problem. One of the ways to really be able to clarify that is by using your previous steroid and local anesthetic type injection to confirm that you got the right spot. And when you know you had the right spot, it can be able to then be able to really keyed in on, so you know you have a potential target that you can be able to then deploy long-term treatment options in order to be able to get some degree of benefit. Okay, so when we talk about spinal cord stimulation, one of the things that we really want to do is to see how does this impact patients with shingle pain and what's their results and how well has this been documented in the literature. And so when we take a look at that, what we see is the following. So there have been a number of different studies that have looked at spinal cord stimulation. As you can see, there's quite a few. And there's been a mixture of different responses. So these have been placed anywhere from C2 to 7.1, and I'm sorry, C2 to S1. And traditionally what you've seen is that you had pain scores of a 7 to 10 out of 10. And then they were able to see at 29 months out, patients that have had pain that has been relieved down to a 1 out of 10. And you've seen it at multiple different contexts of being able to look across. Is it in the thoracic region? Is it potentially in the neck to the leg region? And to be able to see repetitively over and over again, scores that went from an 8 to a 1 to 2, scores that went from an 8 to down to a 1.5 to 2.9 in nature. That's really what we're looking at when we're talking about spinal cord stimulation as a potential option for shingle pain. Now, let's put this with a bit of a caveat of what makes sense and what's sensible from the context of using different therapies, right? So no one really wants to have spinal cord stimulation for shingles pain initially as a treatment option, probably right off the bat. There may be some other things that you could potentially be able to do first. The upside for spinal cord stimulation, which sometimes is delayed way longer than what it should be, is that you can be able to have a trial phase to see whether it works or not. In essence, it doesn't commit you to having a stimulator that's in place that can give you challenges and issues that you're really trying to be able to figure out. How can I be able to not do a lot for this thing that now has afflicted me? So that's really the context of talking about postherpetic neuralgia and how shingles pain can be treated with different options. What's the science behind it? What's the literature? If you're interested in being able to read that article, by all means, please check out our YouTube channel, and it'll be located within the context below of the PubMed resource of how to be able to take a look at that article. And we'll always be willing to help you be able to understand medical literature so that we have a basis in what we do in scientific fact and understanding, so we can help you be able to punch pain in the face and get back to leading the life that you deserve. For those of you who joined us live, thank you so much. For those of you who are seeing us at a later point in time, we really appreciate you tuning into our channel, and we really want to make sure that we're answering your questions and topics that you have. Thank you so much, and have a great day.